In this video, we will talk about subarachnoid hemorrhage, its causes, clinical features, imaging, management, prognosis and complications. What is subarachnoid hemorrhage? Subarachnoid hemorrhage is bleeding into the subarachnoid space, which lies between the arachnoid mater and the pia mater, where cerebrospinal fluid circulates. Key features of subarachnoid hemorrhage: it is often associated with rupture of a cerebral aneurysm, or trauma. It has sudden onset of a severe headache, known as thunderclap headache. It can lead to significant morbidity and mortality, if untreated. What are causes of subarachnoid hemorrhage? It can be due to trauma, or be spontaneous. Traumatic subarachnoid hemorrhage. It is result of head trauma. It is common in accidents or falls. Non-traumatic, spontaneous, subarachnoid hemorrhage. It is due to following causes. Cerebral aneurysms account for 85% of spontaneous cases. It is most common at bifurcations of the circle of Willis, arteriovenous malformations, congenital vascular anomalies. Other causes include hypertensive crises, blood dyscrasias, vasculitis, or anticoagulant use. Pathophysiology of subarachnoid hemorrhage. It has following mechanism of action. Step 1. Rupture of an aneurysm or vessel. Blood enters the subarachnoid space, disrupting CSF circulation. Step 2. Inflammatory and vascular changes. Release of inflammatory mediators leads to vasospasm and ischemia. Increased intracranial pressure, due to blood and clot formation. Step 3. Effects on brain function. Mechanical pressure causes neurological deficits. Breakdown products of blood are neurotoxic. Clinical features of subarachnoid hemorrhage. It has following symptoms. Classic symptoms: sudden, severe headache, worst headache of my life, nausea and vomiting, neck stiffness and photophobia. Neurological deficits: confusion or altered mental status. Cranial nerve palsies, especially cranial nerve 3. Severe cases: loss of consciousness or coma. Seizures. Imaging and diagnosis in subarachnoid hemorrhage. It involves the following series of tests. Initial test is a non-contrast CT scan. It shows high sensitivity within 6 hours of onset, shows hyperdensity in the basal cisterns or sylvian fissures. Lumbar puncture. It is indicated if CT is inconclusive. It detects xanthochromia. Angiography. Digital subtraction angiography is a gold standard for aneurysm detection. CT or MRA are non-invasive alternatives. Management of subarachnoid hemorrhage. Immediate care. It involves stabilize airway, breathing, and circulation. Manage elevated intracranial pressure with head elevation, hyperventilation, and osmotic agents like mannitol. Definitive treatment of subarachnoid hemorrhage. Aneurysm clipping involves surgical ligation of the aneurysm. Endovascular coiling involves minimally invasive embolization of the aneurysm. Vasospasm prevention. It involves administer nimodipine, calcium channel blocker, maintain of volemia and blood pressure control. Supportive therapy. It involves anticonvulsants for seizure prevention, rehabilitation for neurological recovery. Complications of subarachnoid hemorrhage. Early complications. It will show increased intracranial pressure and herniation, rebleeding of aneurysm, hydrocephalus due to blood-blocking CSF flow. Delayed complications will show cerebral vasospasm leading to ischemia or infarction. Long-term cognitive and psychological impairments. Prognosis. It has following prognosis. Mortality: 25 to 50% die within the first 30 days. Survivors: many experience permanent neurological deficits. Better outcomes. Early diagnosis and intervention improve prognosis significantly.